I'd like to thank everyone for being here today. My DNP translational project is entitled Suffering in Silence, Addressing Second Victim Trauma and Resilience in Registered Nurses. I'd like to first take time to both acknowledge and thank my committee members, some of whom are here today, Dr. Susan Thule, my project chair. I appreciate your encouragement and knowledge. Mrs. Meredith Schaefer, my community chair. I appreciate your willingness to be involved in my project and all of your support and encouragement. Last but certainly not least, I'd like to acknowledge Ms. Beth Gaby Smith as an ad hoc member as well. I appreciate your passion for nurses, your dedication to Covenant and Park West, and your encouragement throughout this process. It's no secret that the work of a nurse can at times be stressful. Though I consider it to be one of the most rewarding professions, stressful moments and situations are a commonplace on virtually every shift a nurse works. It also applies to nurses across the country, indiscriminate of their environment. Prolonged exposure to heavy workloads, patient acuity, complex communication that characterizes the med-surg environment could contribute to high rates of stress, burnout, and compassion fatigue among med-surg registered nurses. The normal day-to-day working variables, such as the heavy workloads and increased patient acuity, was exponentially magnified by the COVID-19 pandemic. The stress and strain experienced by healthcare workers across the globe reached a level that no one could have anticipated, nor be adequately trained or prepared to encounter. As clinicians, we may all be familiar with the concepts of resilience, burnout, compassion fatigue, and secondary traumatic stress. However, there has been very little done to integrate focused training to address these concepts in a generalized manner to all nurses. The problem or gap in practice is the need for increased nurse resilience. We've consistently seen the effects that decreased nurse resilience has on the field of nursing. However, there has been no mass formal adaptation to theory into practice to address said issue. We see the effects of decreased nurse resilience through the following statistics on the current slide. International research has established that nurses working in the acute care hospitals are routinely exposed to patient distress, patient trauma, unrealistic expectations, and high workload stressors. Compassion fatigue is associated with things like psychological distress, reduced productivity, and increased absenteeism, as well as the negative effects of caring are likely to lead to a worldwide shortage of nurses by 2025. The purpose of my translational project is to address the emotional health and well-being of medical surgical registered nurses related to the need for greater support interventions to strengthen nurse resilience through the adoption of mindfulness training interventions. My evidence-based practice clinical question is, does the implementation of a mindfulness training intervention increase nurse resilience? The project's significance and need has been established within the profession for quite some time. However, the COVID-19 pandemic exposed just how dire the significance and need for nurse resilience has become recently. Nurse burnout has been linked to negative consequences for the nurse's personal well-being and patient care, to include things like medical errors. It is also linked to greater absenteeism and intentions to leave the profession. A survey conducted by Chung and others in 2020 reported that of the 2,323 critical care nurses surveyed, 17% reported intending to leave their current job within the next year. The Chung study also indicated that high levels of stress and continued exposure to suffering in nursing can make it challenging for nurses to sustain a sense of compassion for patients over time. My PICO question for this translational project is, in medical surgical registered nurses working in an acute care setting, how does the implementation of an evidence-based mindfulness intervention program compared to current practice impact nurse resilience over 6 months? All the literature and associated research in the pursuit of investigating the supportive evidence was found using the following electronic databases: PsycInfo, PubMed, Medline, and CINAHL. The initial search resulted 300 articles, and once duplicate records were removed, that resulted in 200 articles for review. After reading and reviewing the resulting articles, abstracts, and results, inclusion and exclusion criteria were developed. Articles that were chosen to be included in the literature review met the following criteria. They had to focus on burnout, resiliency, secondary victim syndrome. Interventions were present for assessing and addressing previously mentioned issues. It had to be written in the English language, and all selections were published within a 10-year time frame. Articles were subsequently excluded if they did not include studying burnout, second victim syndrome, or resiliency in nurses, and if they were published outside of that designated time frame. After applying the exclusion criteria, approximately 250 articles were not included. That left a remaining approximation of 50 articles to be reviewed. There were 38 articles that were deemed irrelevant to the project, which left 13 articles retained for assessment against quality criteria. 2 were discarded for not meeting appraisal criteria, which left 11 retained studies for thematic analysis. The following articles discussed within the synthesis table were identified as the 5 most applicable driving articles related to my practice problem, interventions, and outcomes. The work by Flaherty and others demonstrated the importance of an educational program to decrease compassion fatigue and burnout symptoms and increase compassion satisfaction in emergency nurses. Chung and others identified a unique approach to preventing burnout in critical care nurses. The article utilizes interventions aimed to increase positive emotion skills while also promoting adaptive coping in the face of stress. The article by Mueller sought to assess the feasibility of a 12-week intervention study to measure resilience, anxiety, depression, post-traumatic stress disorder, and burnout syndrome in ICU nurses. In another article by Flaherty and others, they identified the impact of compassion fatigue and secondary traumatic stress in forensic nurses. Finally, Slatyer and colleagues identified the effectiveness of a brief, mindful self-care and resiliency intervention at improving the emotional functioning of nurses. Some of the gaps identified in the literature include having a smaller sample size or being studied in just one specific location. Most of the studies identified the inability to generalize findings due in large part to having a smaller sample size of nurses and the fact that the studies were conducted at one general facility versus several healthcare facilities. Low response rates were another gap identified in the literature, which affects the results in that it doesn't cover a wide array of the nursing population and again prevents generalization. Pre-existing interventions would include any evidence-based practice intervention identified in the studies that nursing units already had in practice, such as counseling or debriefing, in that it could skew results because they've already adapted some of the interventions. Multifactorial interventions proved to be somewhat difficult to understand and implement to groups during the training, and therefore didn't produce significant results when studied. Age differences between nurses. Resilience showed variance between or based on personal characteristics, but there was also a significant spread between younger nurses and seasoned nurses due to the inexperience and the new nurses' potential lack for experience necessary for having already experienced compassion fatigue. This is a quality improvement design study based on the Iowa model, which will use quantitative data for outcome measurements obtained through the ProQual or Professional Quality of Life tool. I intend to deliver this in a digital format at a pre-intervention, 3-month post-intervention, and 6-month post-intervention follow-up. This tool will assess burnout and compassion fatigue among nurses. In looking at my logic model for this translational project, the resources and input include the 4 Montview and 5 Riverstone medical surgical nurses at Park West Medical Center, myself and my DNP committee members, again, the 4 Montview and 5 Riverstone nurses and managers, an integrative review of the literature, development of a digital presentation of the Professional Quality of Life Survey, and a digital meeting platform like Zoom to disseminate the interventions to nursing staff. My hope with this is to increase the potential and willingness for involvement from all nursing staff. The evidence-based interventions include obtaining demographics on nurses studied and assessing nurse resilience to include burnout, compassion satisfaction, and secondary traumatic stress via the ProQual assessment tool. Also to adopt and deliver a mindfulness training workshop based on Chung's emotional skills intervention and addressing burnout. And then instilling the 3-month follow-up to assess interventions effectiveness, and then again at 6 months via the ProQual tool. and then also establishing open communications with the RNs post-intervention follow-up. So anticipated outcomes, in looking short-term at the 3-month stage, I would anticipate the 10% improvement in burnout symptoms, 5% improvement in compassion satisfaction, and a 5% improvement in secondary traumatic stress symptoms based on the literature. Long-term, at the 6-month follow-up, I would anticipate a 25% improvement in burnout symptoms, a 15% improvement in compassion satisfaction, as well as secondary traumatic stress symptoms. Additionally, the impact of the training will increase the nurse's understanding and his or her ability to apply the acquired skills to increase nurse resilience. In looking at my DNP project timeline, obviously we're in the practice qualifying exam session now. November into the December timeframe, I want to distribute the applications for the nurse resilience training. I'm in the final stages of developing the online digital assessment tool. I'll continue working on that digital assessment tool and updating the nurse manager and hospital team on the progress of the project. In January is when the training will be implemented. We'll also track the resilience toolkit and assess for questions within 4 to 6 weeks. In February to April will be our 3-month follow-up with the nurses and the mid-project reassessment. In May, I plan to continue collecting data, and then that leaves June and July for the beginning phase of data analysis. In looking at the organization being studied is Park West Medical Center, which is part of the Covenant Medical System. Park West is an acute care hospital with more than 1,700 employees, providing the region's leading cardiac services with nationally recognized emergency department and award-winning orthopedics, neurosurgery, and obstetrics units. It's located in Knoxville. It's a 307-bed hospital. Fort Montview is a 33-bed complex medical unit, and 5 Riverstone has 44 beds. Barriers for approval were obtained, and then the CNO approved with added support and recognizing project value from the nursing educator and Fort Montview manager. In looking at nursing demographics, the nurses on Fort Montview are comprised of now travelers, full-time and part-time nurses, to include new graduates. There's approximately 20 to 30 nurses per unit, night and day shift. And then the age ranges for nurses vary. So we have our new grads, and then we also have seasoned nurses. So those age ranges can go from 20 to 60 plus. While conducting my SWOT analysis on the organization, the following was identified. So some of the strengths include the corporate presence is seen and felt by nurses. You can frequently see members from the corporate team on the floors introducing themselves and speaking with nurses, also encouraging open lines of communication with the nurses. There's a welcoming environment to patients. So the cleanliness, the decor, friendly smiling faces, and there's an individualized approach to caring for patients and families. So we can see this in things like cleaning cards from environmental services in each room, call lights being a no pass zone, or what they call a no pass zone, picture and contact information for the floor manager in every room on the patient data boards. Those patient data boards are updated each shift, detailing the treatment plan and care team, and they also have bedside reporting. Some of the weaknesses identified within the organization include increasing nursing turnover, changes in nursing leadership, and increasing patient acuity, which also increases the patient to nurse ratios. Opportunities, so these are things that give or could give the organization an advantage. The organization is very visible in the community. They have continued efforts to fast track care and triage patients. They continue researching ways to recruit and appeal to different nurses, and their nurse residency program is highly advertised, also increasing their partnerships with the local nursing schools. Some of the threats identified to the agencies, these could be things that could potentially harm the organization. I would include competitive pay with local area hospitals, their nurse recruitment and retention. There's an increasing appeal for travel contracts to nurses lately, and then also patient satisfaction surveys when they've been understaffed. So in looking at the theoretical framework utilized for my translational project, I used Polk's theory of resilience, which is a middle range nursing theory developed by Laurel Polk. Polk sought to identify how nurses intended to promote wellness through both rehab and psychosocial change. Polk identified and clustered attributes of resilience into 4 clusters to include the physical and psychosocial cluster, the roles and relationship cluster, the problem-solving cluster, and the philosophical cluster. And this is just an illustration of Polk's theory of resilience to the left. So if we look at Polk's theory and resilience interventions, the physical and psychosocial cluster, also termed dispositional, we would see this in the intervention component with individuals' experience, their internal strength, their self-worth, their autonomy. These are going to be things like the self-care and mindfulness exercises and positive reframing. If we look at the roles and relationship cluster or relational category, the interventions are going to be debriefing and huddles, peer-to-peer support, things like shout-out boards. The problem-solving cluster or situational cluster, we're going to see this in the interventions when we look at like reflection and debriefing after a traumatic event. And then the philosophical cluster, we're going to see this through nurses with their optimism, positive emotional skills, culmination. These are all things that are going to be taught through the training. So Polk believed that the clusters interacted together in a synergistic manner through time. Polk merged the paradigm of both the environment and human energy together with the 4-dimensional patterns of resilience, which I listed: dispositional, relational, situational, and philosophical. She explained that when a stressor is introduced into the system, the person and environment experience chaos or disorder. While undergoing changes in an attempt to restore homeostasis or equilibrium, the 4 patterns of resilience interact and come together in a synergistic manner to move the situation from a situation of chaos to a higher order of balance. She coined this entire process resilience. So in looking at my sustainability plan for my translational project, ideally the nurse resiliency training would be adopted and incorporated into staff training at Park West Medical Center on a regular basis with their other staff trainings. Nursing administration would provide the nurse resiliency training and continue implementing the structure of the pre and post intervention follow-up with the use of the ProQual assessment tool and positive emotion skills interventions. Ultimately, the goal is to decrease nursing turnover, burnout, and secondary traumatic stress associated with the healthcare environment, specifically at Park West on the medical surgical units of 4 Montview and 5 Riverstone, with the hope that the program will be adopted facility-wide. Here are some of my references for the presentation. That concludes my presentation of my translational project focused on increasing nurse resilience in medical surgical registered nurses. I'd like to now open it up for any questions.
Thank you, DeOnna. I see that Ms. Schaefer has been able to join us. So Meredith, I'll open it up to you first.
Sorry, I'm on my phone. I thought that was very good, DeOnna. And, you know, I'm on that Focus 2021 with Neil for the whole organization for Park West. And he is looking into mindfulness right now and some sort of app for nurses to be able to use. So I think your project will definitely be implemented into the hospital wide. So I think that's really awesome.
Thanks a lot, Meredith. Thanks for tuning in too. I know you've got a lot going on, so I appreciate it.
And Meredith, I want to thank you so much for agreeing to serve as DeOnna's community member on her committee. Without our community members, our students wouldn't have projects and practice sites. So I really appreciate, especially at this time, your with all the demands you have, I really appreciate your support of both DeOnna and myself. Thank you so much.
Of course. Thank you all.
Are there questions or comments, feedback for DeOnna?
Hi, DeOnna. If you'd be open to it, I would love to connect you with a very good friend of mine who I've actually been working with a little bit. She's a Pittsburgh-based nurse practitioner that has actually founded a program called Resilient 7, which seems like a very similar kind of project to what you want to implement. It's essentially mindfulness and resiliency training for nurses specifically. And she implemented it on her medical oncology unit. And I'd definitely be interested in giving you her information and a link to the program, just so you can kind of use it either as a reference or a guideline, or maybe ask her for, some help with anything that you need. She's super open to working with others. And if you'd be interested, I'd love to give you her information.
Awesome. Yeah, I'd really appreciate that. Thank you, Summer.
Absolutely.
Summer, you bring up a good point. One of the goals of our immersive community intensive is to establish connections. Because you all are at different levels in different classes, you can always reach out to each other via UTC email by going to the DNP org site on Canvas and looking at people, and that will allow you to access the email and contact information for those enrolled in the DNP org site. So thank you for spurring me to reinforce that to all of you. But again, everybody is listed in the DNP org site on Canvas.
I had one question. About you mentioned mindfulness interventions. Was there any specific interventions that you're doing? What's an educational session, or were there resources, or is there a tool that you're utilizing in order to help your staff with their resiliency through these mindfulness interventions? I was just trying to jot down what the actual specific interventions were.
Yeah, thanks for the question, Kyle. So the work in the synthesis table by Chung and others detailed an emotional health toolkit. So it would include things like brief mindfulness exercises, like 5-minute imagery or guided imagery. Some of it could be like journaling. I've still got to pick out which ones I want to tailor to the to those nurses, but it'll just be like really quick things that they can do at work, after work, at home, and that'll take roughly about 5 minutes for them to kind of go through and kind of decompress and go through. It even includes things like exercise and everything. So I'm hoping to explain those things to them in person, but also set up like a Zoom recording so that these nurses that are already taxed for time can also access it, on their own time and not have to come in on their off day.
Sure. I'll just let you know, I think Natalie Hall was on my team in healthcare policy and 2 others. And we wrote a paper on nurse burnout and things of that nature. And there were a lot of free services online, especially with COVID, for nursing individually, that provided a lot of free education and free resources, not only just nationally, but locally. I don't know if you've checked into that. I'm happy to send you that information as well.
Hey, I'd appreciate any information you can provide. So thank you so much, Kyle.
Yeah.
Hey, it's Tammy. So I love this topic, the second victim, and I think even more so now with the pandemic, it's much needed. But I remember several years ago when I was a staff nurse in the operating room at a level 1 trauma center in your town, that when we would get traumas and deaths in the OR, there's not any acknowledgement of what the nurses or anyone involved in the case goes through, and any coping, or if it hits home just for personal reasons that might have happened in their own life. And then it's just like, go on to your next assignment. You just move on without any acknowledgement of the person and the loss that just happened, including when we do organ retrievals, which is extremely hard on the OR team. So one question that I had was, do you, with some of your interventions, have you thought about having like some support groups where people can just come together just to talk about their experiences and help each other cope with what is happening at work?
Yeah, thanks for sharing and thanks for asking that, Tammy. So I will be the first one to say that this project pushes me professionally and personally because I'm not one that deals in feelings often. But having been an ER trauma nurse, also in Vegas during the October 1 shooting, it was something that I was faced with, and something that, like you said, we just, as nurses, we just suppress, because who has time to really feel those feelings? And so I have found value in the debriefing and just sharing in group settings if people are comfortable. So I'm looking forward to implementing this on these two particular units. One unit, the 5 Riverstone, was impacted heavily by COVID. Ordinarily med-surg nurses who just had never, ever even had to dig deep critically like that. And then for Montview as well, they're very tight knit units. And so I think their willingness to share and open up is going to be far greater than what we would see in like organ retrievals or critical care or ED. So I'm excited to really present to them the opportunity to sit and debrief just with a handful of nurses, even, because I think that they're willing to discuss their feelings, which is great for me, and also just personally pushing, because I'm not an emotional person. So thank you.
Is there any other feedback or commentary for DeOnna?
Hey, DeOnna, it's Casey. Coming from a med surg unit, I think this is so important. I did ED and critical care very, very little in my career, but like you said, it kind of, you get used to it there more than you do in other units. And coming from an oncology unit, especially with our new nurses, they're just, like you said, that second victim. And I think this is really important resilience wise, because it does help with the debriefing, but you can still see that fear there. Because you don't see it as often in med surg. You just, if they're that sick, they go to critical care, and that's where anything else happens. So when you actually have a code and they don't survive or get transferred before they expire, it's really traumatic. And I think this is so important for med surg nurses. So I think it's a great project.
DeOnna, I think it's a great project too. You did a great job. And since I'm at the same facility quite a bit, if you need any support or in any way, if I can help with the project, just word of mouth, please let me know. I think it's a great plan.
Thank you. I appreciate it, Andrea. And Casey, we also would see, I would show up to work or I would be there with my students, because I also do clinical there on Fort Montview. And, nurses are just naturally invested. And the anxiety behind these situations when a patient would code, or, if we had to transfer them to critical care, those nurses would say, hey, how are they doing? Are they still hanging around? Or, what's going on with them? And so they would go day to day and shift to shift and just worry about those people. And the numbers were just through the roof with COVID. So I definitely could see the change.
Well, and I think too, the fear is I've missed something. And so they harbor this guilt that they've somehow harmed their patient. And so I think the second victim is just a perfect title.
Thank you all so much for your comments and your feedback. We are at time for our lunch break. We will have an hour for lunch, and we will come back at 12:40 Eastern time. And we will hear in our first session from